everyone. Welcome.
Hi, everyone. Nice to meet you all.
We will give everyone just a minute to sort of come in and join us. Um, Hi, Trisha. Hi, Sandy. Maybe while we're letting everyone join us, maybe we could learn a little bit about where everyone's joining from. And curious to hear about maybe what you're interested in learning from Dr. Weissman tonight. Woohoo! We've got Dallas, we've got Arkansas, Arizona, Iowa, Twin Cities, Florida, Virginia, more Florida. Oh, vet
Texas
student
in
from
there.
Ohio, love this. Long Beach, South Florida, Tennessee, Texas, New Jersey, Connecticut, Michigan, Atlanta, more Texas, New York City. Hey, Mike. See Mike. Orange County, Washington, Louisville, Texas. Oh my gosh,
Oh,
this is
awesome. There's so
so
many people
cool.
joining us.
I'm coming in from Boston. I live on the West Coast, but I just had the exciting chance to attend an event all about AI and innovation in animal health and talk more about Radimal. And excited to share some of what we talked about there today with you all. Woo, we've got Red Bank. That's where
Like,
Dr.
that's where, exactly. I'm in Red Bank, New Jersey. Lived most of my life on the East Coast here, so I haven't made it too far.
Awesome. More from Texas. And maybe people can share with us, yeah, what are you hoping to learn, or what questions do you have about radiology or AI? Anything else that we can hope to address for everyone today before we dive into some cool cases? Oh, yes. I love Allison. She's got snacks. She's going to enjoy. That's my type of person. Mm, wonderful.
Radiology is meant to be enjoyed at home in your pajamas with
Exactly.
some popcorn.
Yes. Snack, whatever snack you like, really.
Exactly.
Cool. Well, okay, let's see. This is an awesome comment. My radiology professor from decades ago used to say, put on your imagine scope. This is awesome. St. Louis. Okay. Well, I'm going to give everyone just one more minute and then we will kind of introduce ourselves again formally and then begin our webinar. Oh, wonderful. Okay. Perfect. Well, it is just a few minutes after, so we'll just dive in. Love to learn. Ooh, yes, this is great. A little body workout. Now we're gonna have a mind workout. I'm very impressed. Wonderful. Great. Well, thank you all for joining us tonight. We're so excited and really honored that you've taken some time out of your busy schedules to talk about radiology with us. My name is Madison Alig. I am the Director of Clinical Relations with Radimal. And like I said, we're just so excited to have our very first race-approved Radimal Case Rounds webinar this evening. And at Radimal, we see so many really interesting radiology cases every day. And so we thought, why not share them with our veterinary community at large? So that's why we created this webinar series called Case Rounds, and just super excited to dive into some of the most interesting recent cases that have come across our platform with this community of curious minds. So what makes Radimal extra interesting and cool is that we're not just going to look at these cases from one angle. As you might have heard, we're also going to look at all these cases as they were interpreted by our AI initial assessment tool, as well as from a board-certified radiologist, Dr. Weissman, and to understand how both of those perspectives can work and support you in your clinical decisions. And so if this is your first time with Radimal or hearing about us, we are a leader leader in veterinary radiology services. As I mentioned, we combined AI-powered initial assessment tools to help you triage your cases and then be supported by full boarded certified specialists for consultations anytime you need support with radiology, with reliable imaging insights 24/7. And without any further ado, I'm really excited to turn this over to Dr. Andrew Weissman. He is our co-founder and our chief medical officer, and just kind of the inspiration behind all things Radimal. And before we dive in, like I mentioned, super excited to receive all questions that you may have. So please feel free to put them in the chat or the Q&A, and we'd love to be able to answer them in real time as they come up with any cases that we're discussing. So please don't hesitate to ask anything. And with that, thank you so much, Andrew.
Thank you, Madison. Thank you everyone so much for being here. I really, we all really appreciate you taking the time to join us. It's really exciting that we're gonna have this case series, and we're really excited to show these cases. All the cases we're gonna look at tonight are real cases that have come through Radimal in the last few months, with the real initial assessment powered by AI, as well as the real report from the board certified specialist. And so, yeah, we're gonna get to it, and we'll go through a few cases. Let me just share my screen, which is the most difficult part of this whole thing for me. 1 second. All right, I'm gonna share here. Let's put us into presenter mode. All right, Madison, can I have a thumbs up if you can see things?
You did it.
Perfect.
Perfect.
Love
Thank
it.
you.
All right. The hardest part's over. All right. So, like Madison said, I'm Andrew Weissman. I'm a board certified radiologist. I've been doing this for 10, 12 plus years. I graduated from UPenn in '09. I did a rotating internship at a private practice up in Rhode Island, and then did my residency at Tufts. And since then, I've been doing in-clinic radiology work at Red Bank Veterinary Hospital in New Jersey. I'm also an active teleradiologist, both with Radimal now and over many years with a variety of different teleradiology groups. I serve on the ACVR's DEI committee and the AI committee. And yeah, I'm so excited to be part of Radimal, and it's something that I feel really passionate about, both the radiology component and the AI component, as well as teaching. And so I'm so excited for us to start. So what we're going to do tonight is we're going to go through 5 cases. You'll see there's going to be an opportunity for you guys to put into the chat kind of what you see on the images. And that's really helpful, both in terms of, I think in radiology, once someone points something out to you, it's really easy to be like, oh, I knew that's what it was. But I think it's a little bit different when you have to kind of put your answer in the chat or on paper. And so if you guys are able and willing to participate, that would be awesome. And it can also help guide some of the discussion that we're going to have. So the first case we're going to do, we're going to start off pretty basic, because I think one of the things I'm hoping that you'll take away from this lecture is how to use AI in radiology. So we're going to start with Nala. She's a 2-year-old French bulldog. She presented for ADR. The owners knew she was pregnant, but she just hadn't been herself, and the owners were worried that something was wrong with her. And so again, these are the real radiographs. And so as you'll see, as we move through this, some of the rads are better positioned than others. Again, this is just how they come to us. And so that's what we've got to work with. And so the plan is, I'm just going to put these images up, give you guys a few seconds to look at them. In a little bit, I'm going to ask you guys how many fetuses there are. So please count them. And look for any other abnormalities that you think might be significant in a case like Nala's. I think one of the things that we often see when it comes to fetuses is we look at fetal size. And I do just kind of want to put a little side note out there that there are some cases that I've seen where there might be 1 fetus or 2 fetuses, and the fetus looks massive in relation to the size of the dog. And to look at the radiograph, you would think like, oh my gosh, this dog is definitely going to need a C-section. But I've been really shocked at the size of puppies that dogs are able to push out the birth canal. And so just as an aside, even though on radiographs puppies may look massive, that doesn't mean that the female isn't able to push it out of the birth canal. Hopefully that's enough time for you guys to
Oh,
all look at
yes.
these.
Andrew, we've got lots of great responses.
Oh, yes.
I'm seeing three. I'm seeing four. I have one answer. Four. One is engaging the pelvic canal. Uh,
Yes, that's right.
oh, great job.
I
Um,
love it. One of the questions I have for you guys is how do you count fetuses? I think this is my first time using a poll, but I think you guys can click on that and vote whether you count heads or tails or some other way. Is that true? Is that working, Madison?
let me. It's not letting them click, but let's just put the responses in the chat. What
Yeah,
I'm seeing so far. Head with spine, head and spine, spines, heads, heads and spines, heads, and try
love
to
it.
confirm with spines.
Perfect. So that's kind of what I like to do too, and we're going to kind of walk through that together. So the first thing that happens with at Radimal is once you submit a radiograph, or excuse me, once the radiograph is taken from your machine, it automatically is read by AI. And what comes up first is an AI generated report. And one of the things that's really important is that you can look at this and understand that it is AI generated. So if you can see, oh, this line is not very thick. There we go. You can see that it says it's AI generated. So this report has not been made by a specialist. And so this report might look a little different than most of the radiology reports that you're used to looking at. And so what we have is up at the top, we have all of the conditions that the AI has identified. So AI is going to look at each radiograph for a variety of conditions. It doesn't read the radiograph as a whole. It assesses for all these specific individual conditions. And then it's going to determine whether that condition is likely, possible, or potential based on how many images it finds it on or how likely it fits with what the AI knows about that disease process. And so when you get this AI generated report, the goal of it is to kind of in clinic within minutes have some more information that will help you as the clinician move on to treat that patient or potentially to seek a radiology consultation. So I just want to take a minute. We're going to go through this one kind of line by line here. All right. So the first AI finding is that there's a fetus, right? And so one of the things we're going to look at when we look at these AI reports is it's going to highlight where the AI is sort of looking. And so we can see on this image the AI is looking at the fetuses, so that makes me feel comfortable that the AI is looking at the correct thing. We can see that the fetus was detected in 3 images. In this case, I only showed you guys 2, but there were 3. And so it saw it on multiple images. That also should increase my index of my degree of confidence in this AI finding. And also my radiograph is pretty well positioned to evaluate the fetuses. The next AI finding is coxofemoral degeneration. We can see that there is some mild thickening and widening of the femoral necks. And this is one of the places where I think AI really shines. It's very easy to get caught up looking at the fetuses, and you might miss some subtle things, whether it's coxofemoral degeneration or some more significant things like edge of lesion, aggressive bone lesions, edge of lesion pulmonary nodules. That's one place that AI really shines and makes a difference, because AI works the same way, whether it's the first image or the last image of the day. It never gets tired, and so it really is a great supplement when looking at radiographs. The next AI finding is hip dysplasia. So I want to talk about why I do not think that this AI finding is correct. And that's because the radiograph is not taken appropriately. It's not positioned appropriately to evaluate for hip dysplasia. We can see that these femoral heads, the AI is reading it as hip dysplasia because there's poor coverage of the femoral heads. But I don't know what it would look like if the femoral heads were, if the femurs were pulled down straight, if the femurs were internally rotated. And so even though it is saying that it identified hip dysplasia, I do want to question that finding, because that's not what these radiographs were intended for, and they are not appropriately positioned for that. And so that's important when you're talking about AI, because AI is a machine, it is a computer, it is not a doctor. And so throughout this lecture, we're going to talk about how only doctors make decisions. We're going to use the AI to help inform our decision making, but we're not going to rely on the AI as a standalone. And that is, in truth, how we recommend using it and how it's used in human medicine as well. All right, so we're going to go back to these radiographs. Sorry, I guess when I drew on here, I didn't realize it was going to stay. So let me just erase this thing here so we can get it out of the way. All right, so back to these radiographs. How many fetuses are there, Madison? Was there a number that seemed more common than others that people saw?
I think 4.
All right. So I also like to count spines and heads. So here's the spines. And I think it's really important to do it on more than one view. I know it's tempting to just take one view and be like, oh, I'm just looking for fetuses. How hard is it? But fetuses really can hide a lot of different places, especially when there's stuff in the stomach. And so I think there's 4 fetuses here on both views when I count spines. And when I count heads, we also have 4. So I agree, there are 4 fetuses in this study. One of the things that I want to touch base on when we're talking about these AI generated reports is that I think it's easy on one hand to look at this case and be like, AI didn't add a whole lot for us, right? I knew there was a fetus. Any, first year vet student can tell me there's a fetus. But one of the things that is important is ruling out other possibilities. Things like, is there free gas in the abdomen because of a uterine rupture? Is there peritoneal effusion because there's some kind of complication associated with pregnancy? Is there one of those edge of image lesions that we might be missing because we have tunnel vision? And so if we look at the AI report, we can see over here in the checked section that the hepatobiliary system, spleen, and importantly for Nala, that the peritoneal space has been checked and is normal. And that's an area, again, where AI really shines. And I just want to reiterate that even when we're looking at these basic cases, there's a lot of room for AI to really up our interpretations. In Nala's case, the veterinarian who was seeing Nala felt comfortable both with their own interpretation of the radiographs and with the AI, that they didn't request a specialist consultation. And that seems completely appropriate. And so, they treated Nala for her ADR and sent her home, and she did well. We're going to take a look. Actually, before I go on, any questions about Nala or the role of AI in looking at Nala's images? I didn't go through all of like the gastric material and anomalous vertebral bodies in the interest of time, but there were some other incidental findings for her. All right. So let's go on to something a little more complex.
Oh, excuse me, Andrew, before we go on, could you
Yes.
go back and we have one question saying, why ADR?
To be honest, I don't know. That's just the history that we got that the dog was ADR. I will put a plug in here that anytime you're sending a case out for Telerad, the more clinical history you can provide, the better we're able to give recommendations. Is she ADR because she is having tremors and we should recommend, checking a calcium? Is she ADR because she's having vaginal discharge? I totally agree with you. Great question. I have no idea because that's what we were given.
Thank you. We have one other question asking, can AI age fetuses?
AI currently does not age fetuses. There are a few good references out there that talk about, can you see the radius? Can you see the teeth? Because that's really how you're going to identify what day of gestation they are. I think that that is something that we will certainly look to do in the future. But currently, it does not age fetuses, although I acknowledge that is certainly something that would be incredibly helpful.
We will take that to the suggestions. Thank you so much, Chris. Okay, let's go to the next case, please.
All right. Georgie is an 8-year-old bulldog showing presenting for progressive lameness. And so we're going to do the same thing. These are radiographs. We can see right off the bat, I hope you're seeing these human hands. If you submit radiographs like this to Radimal, you will get a private note. It doesn't go in the report. It goes directly to the vet that, there is a human body part in the primary beam and that this is a safety violation. And, at Radimal, we take radiation safely very seriously. And we want to, sometimes it may not be as obvious and we want to point it out to you if the technician's hands or a doctor's hands are in the bean. Um, but again, these are real cases. This is how it came to us. And so this is what we've got. So I'm going to give you guys just a few minutes, well, a few seconds to look at it. Um, and I'd like you to maybe in the chat put how many findings you see on these radiographs. If you're feeling confident, you're also welcome to put, if you know what some of the diagnoses might be, feel free to put those in as well.
Thank you to our first brave respondent. They said 3. Another person has also 2 more, 3, another 3, 4. Anyone want to list anything they might be indicating for? Seeing some 3s, maybe 2 to 3, 2, 3.
I'd love if someone's brave enough to put what they think
Oh,
some of the
okay. They put it
diagnoses
in now.
are.
This is going to be the scary part because I have to pronounce it. I'm so sorry. I'm not a medical person like you all. Okay. Okay. Osteomyelitis at
Uh-huh.
distal fibula. I have
Okay.
aggressive lesion at the tibiotarsal joint.
Perfect.
Lyric lesions. Femoral head is not good. Tarsus is not good. Inflammation of soft joint in the tarsal joint.
Okay.
The hook appears lytic, lumbosacral disease, and then synovial cell sarcoma. Thank you
All
all.
right. We've got some awesome diagnoses here. And so, if you're seeing this case in clinic, these are your radiographs. Maybe you have, maybe you're one of the people that put those notes in. Maybe you're like, I think there might be, I see some soft tissue swelling, I see some lysis, I see some spondylosis. So what's going to happen next is let's look at that AI generated report. So here's the report, which found 3 things. It found an aggressive lesion, stifle effusion, and spondylosis. And so let's go through those 3 things together. So first up, aggressive bone lesion. So we can see that the purple area is highlighting the tarsus. Maybe that's the area you were looking at. We can also see the purple area is highlighting up here. And this is another example of where when you have so much superimposition, poor positioning, the AI just does not know how to interpret that. And so it could have said that was an aggressive lesion. It could have said that was a big liver. Like the AI just is not able to identify what is happening in those scenarios. And so it's important, again, to kind of ask yourself, is the AI evaluating the right area and is the radiograph appropriate for it to evaluate that area? So we're going to completely ignore this and we're going to look at the aggressive lesion there. When we are talking about stifle joint effusion, again, we're looking at it. Is it evaluating the correct area? Yes, it identified it in 2 images, which should give us pretty good confidence in this finding. Spondylosis, it only detected it in 1 image, although I think that may be the only image where the spine was included. It is looking at the correct area, but truthfully, it's incidental, so we don't really need to spend a whole lot of time on that anyway. All right, so let's go back to these images because remember, if you're the clinician, you have to decide now, do I feel confident enough to treat this patient? Do I need to reach out to a radiologist and get a consultation? What are my next steps going to be? So this is the zoomed in view. We can see that there's some moth-eaten lysis of the tarsus, of the tibia. We've got some lysis of the fibula. It's a little bit harder to see on this craniocaudal projection, but you can see there's like multifocal areas of lysis in all these bones. Madison, are you able to see my arrow that I'm using?
Yes, thank you.
Okay, perfect. And then there's significant soft tissue swelling there. And so again, because we have lysis of the calcaneus, probably the tarsus, the fibula, the tibia, this is going to be a polyostotic aggressive bone lesion. And so, this is an area where you really would benefit from a specialist consultation. The AI in and of itself will say it's aggressive, right? But an aggressive lesion could be a monostotic aggressive lesion, an osteosarcoma. In this case, it's a polyostotic lesion, which is very different, right? Our differentials for a polyostotic joint associated neoplasm are going to be synovial cell sarcoma, histiocytic sarcoma. And so, what you tell owners is going to be different as a result of that. And so in these cases, when you see something concerning on the AI finding that you yourself were also concerned about, I think it's really important to go ahead and request that specialist consultation. And again, the AI is there to assist you, but it is not meant to replace a radiologist. That is not the goal at Radimal ever, and should not really be the way that AI is currently used in vet med. And so the clinician went ahead and requested a specialist consultation for Georgie. I happen to be the person who wrote this consult. And so we now on these specialist created reports, you can see it has a somewhat similar look to the AI reports, except it only is going to show the abnormalities. And we do this, we bring them right up to the top so that if your technician is the one looking at the report, if you're taking this into a room to show an owner because you want to recommend 3-view thoracic radiographs, you want to recommend a surgical consultation, the owners can look at this report and be like, oh, the vet is showing that there's something aggressive, there's soft tissue swelling. And that really can increase compliance for owners to then go see a different specialist or do the follow-up care that you're recommending. And in the Radimal radiologist created reports, you still obviously get all of like the regular clinical notes, including summary recommendations and things like that.
Just a reminder, if you do need, you can put your mouse over the presenter screen and zoom in case anyone is interested in being able to zoom in and see the report in more detail.
Perfect. Any questions about this one before we go on? We didn't really talk about the joint effusion too much. I'll just go real quickly into this, but there is stifle joint effusion, and we can tell because there's increased soft tissue opacity over the cranial aspect of the stifle joint. We have caudal joint distension and some degenerative changes, which are from the laxity of the joint. And while we might think like, oh, this isn't really a big deal, who cares? This may be a contributory cause of the dog's lameness. Obviously, not what is ultimately going to limit the dog's lifespan, but certainly when we're talking to owners, like not only does this dog have tarsal pain, but he probably also has stifle joint pain. And so his lameness may be even more exacerbated. Any questions before we go on? Love it. All right. So next we're going to talk about Nikki. Nikki is a 12-year-old Schnauzer. She's presenting for coughing and labored breathing. These are Nikki's radiographs, full body, which as a radiologist, I have to tell you, please don't do, but we get them commonly. I understand how it happens, but it's certainly easier to make appropriate diagnoses when things are collimated to the correct body region. But nonetheless, here we are. These are Nikki's rads. And so I'll give you guys a few seconds to look at things. Similar to the last one, there's obviously a couple different findings. Feel free to put in the chat if you have some diagnoses to make.
I'm seeing bladder stones, large heart, microchip bladder stones, cystic calculi, CHF, cardiomegaly, left heart failure, CHF, enlarged heart, bladder stones, cardiomegaly.
Awesome. All right, let's go through it. So the first thing again, we're going to look at that AI generated report. So we can see that there's a lot going on with Nikki. And some of these are going to be a little bit redundant in terms of the cardiac enlargement, and we'll go through those. All right, so detailed findings. Cardiomegaly detected on 3 images. We can tell it's looking at the right area. We should feel confident in this finding. And in general, with AI, any disease process that looks the same, like left atrial enlargement, bladder stones, things like that are really where AI shines. Places that are a little more tricky for AI are things like fractures, aggressive bone lesions that kind of look different from patient to patient. But certainly left atrial enlargement, that's actually how Radimal started, was a file of 100 cases of left atrial enlargement and proving to myself that AI could, in fact, identify which hearts were big. And so, true to form, AI is wonderful at identifying left atrial enlargement. And so you might notice in this case, so we have cardiomegaly, it's identifying left atrial enlargement. And so you may ask yourself, like, well, you already said the heart's big. Why are you continuing to say it's big? It's just that depending on whether there's generalized cardiomegaly or left atrial enlargement, the models kind of run through all of those different possibilities. And so it may select for more than just the one and it'll show two. And again, that can just increase the degree of trust that you put in that AI finding. And so now we're going to go on to the lungs. It's identifying an interstitial pattern. Here is an interesting one to me. So it's identifying bronchopneumonia. So if we talk about bronchopneumonia, it's either an interstitial or an alveolar pattern, and it's ventral, right? If we remember back to vet school, it's cranioventral. And so the question that I'm going to have, like in my own mind now, if I'm the clinician, I'm like, I was thinking there might be heart failure. The AI is showing pneumonia, but I know that an interstitial pattern is going to be present in heart failure or pneumonia. And so it may be that Nikki has concurrent pneumonia, it's ventrally located, or maybe she has some cardiogenic pulmonary edema that happens to be ventral. And so sometimes we kind of need to critically evaluate whether those AI findings make sense in light of the case. And truthfully, I don't know the answer. Does Nikki have concurrent bronchopneumonia, or is there edema that just happens to be more ventral? And then we can see that the AI is detecting congestive heart failure on all three images. So for me, the fact that we have left atrial enlargement, cardiomegaly, an interstitial pattern, congestive heart failure, like the AI is basically like, big red flashing lights, like, hey, this is what the AI is evaluating in the patient. And so when we see something like that in an AI generated report, it should really get those alarm bells going and can help you as a clinician identify, like, hey, maybe this should go out for a stat consultation. Because hopefully between your own interpretation and the AI interpretation, you feel comfortable giving a dose of Lasix, putting in an oxygen, whether you're shipping it off to a different facility or treating it in-house. But having that stat consultation at Radimal, they come back either within an hour or an immediate stat. I want to say that the average time is like under 15 minutes. Those really can help you get that specialist consultation so that you can continue to offer the appropriate treatment to your patient. I just want to go through the rest of Nikki's AI findings. Hepatomegaly, cystic calculi. This was an interesting one. I don't have a good answer for why it's not looking in the right place. And actually, when this case came through, it triggered a retrain of our cystic calculi model to make sure that we are looking in the right place. And so, again, these are real cases. We want to show you all of it, the good and the misses. And this was a miss that triggered a retrain for us. And then spondylosis. So I just want to go through real quick and pretend we're back in vet school. If we remember the clock face analogy, the left atrium is right here. And so when that trachea gets dorsally deviated and you get flattening of the caudal border of the heart, it's that backpack sign. I also just want to draw everyone's attention to the fact that the left atrium is here and not over here, as we sometimes forget. So then when we go back to this case, so again, here's the left atrium. We can see that whereas on this radiograph, the trachea was downward sloping and the caudal part of the heart sort of just had like a nice downward slope. When we look at this heart, it's got this nice backpack here, flattening of the caudal border of the heart, dorsal deviation of the trachea. On the ventrodorsal projection, here is the left atrium. It's a little rotated, but I hope you all can see like this kind of almost looks like a ping pong ball right there. And what happens is you get lateral deviation of the caudal main stem bronchi, that cowboy sign, depending on where you went to vet school, might sound familiar. And then we want to also look at the vasculature. Let me get my pen out here. So if you remember, veins are ventral and central. And we go artery, bronchus, vein. So the vein is here. Change colors. Artery is here, and the bronchus is in between them. Any questions about that? I know that can always be tricky, and I can draw them here on the other side too. Right? And so we kind of were taught in vet school that if the veins aren't big, then it must not be in failure. But I just don't think that's true, especially if a patient is being treated by a cardiologist and is on Lasix, or maybe has already gotten a dose of Lasix while you were taking radiographs or before you took radiographs. And so I do use vasculature to inform my decision, but it is certainly not a standalone finding that I need to have to identify congestive heart failure. And so, if we remember back to vet school, the most common location for pulmonary infiltrates for heart failure is going to be perihilar slash caudodorsal. And so, what does that mean? On the lateral projection, perihilar caudodorsal is kind of in this and this area. What I'd like to impart on you is please don't make a decision about heart failure on the lateral radiograph. There's caudal vena cava, there's aorta, there's left atrium, there might be fluid in the esophagus. There's too much happening on the lateral projection. Do not make a decision about left-sided congestive heart failure on the lateral. You're only going to use the DV-VD view. And when we talk about perihilar caudodorsal, the area you're looking at is in here. You can see that there's an interstitial to alveolar pattern here, in here, and here. I do think these vessels are big, particularly on the right, maybe a little bit on the left also. And we can see that there is an interstitial pattern in the right cranial. And I think that's what the AI was picking up with the pneumonia. Again, I'm guessing that this is all just cardiogenic pulmonary edema and not pneumonia. But if your patient, is febrile or had a history of vomiting, maybe it makes sense to put this patient on antibiotics. And so again, it's just the AI is adding all these little tidbits, but as the clinician, it's your responsibility and job, as you know, to kind of put all these pieces together. Before we go on to the specialist report, any questions about left atrial enlargement, identifying vessels, how to identify congestive heart failure? If you take nothing else away from this, just remember, please use the VD-DV view, not the laterals, for identifying congestive heart failure. All right, and so when we go look at the specialist report, again, this is all created by the specialist, not AI driven. And we can see that there is congestive heart failure, the cystic calculi, all those things we talked about. And again, we have those checked items. So we can see that there wasn't anything in the peritoneal space or anywhere else that we're missing. You get, all of the findings as well as recommendations in this case for an echo Lasix therapy. Any questions on Nikki? Anything I can clarify? I can't really show you the cranial vessels that well on Nikki because I genuinely just don't see them. We've got this little bronchus here, but I can't see the vein and artery very well. And sometimes that's just the way it is. And so in this case, I think these right caudal vessels are the most prominent and easiest to see.
Andrew, we have one question. Do you do VHS?
So I don't do VHS. However, I think it's completely reasonable to do a VHS. I can show you guys real quick how to do it for anyone who's not sure. Anyone who doesn't know, it's the vertebral heart score, vertebral heart scale, actually, I believe. So you're going to drop a line from the carina to the apex. It's supposed to be straight. And then again, what's supposed to be a straight line kind of over the thickest part of the heart, it actually should probably kind of look like this. And then you're going to compare it to the vertebral bodies. And so the most of the number that's in my head, at least, is 8.5 to 10.5. For VHS, there's a lot of variation depending on the breed, especially if it's a boxer, it's a Doberman, things like that. So I said I don't do it. That's not entirely true. Sometimes when I'm really just not sure if the heart is big, I do a VHS. And if it's 12, I'm like, great, it's big. And sometimes that's helpful if there's not left atrial enlargement, but there's just like generalized cardiomegaly where I'm not really sure what's going on. Or if you do a VHS and it's 8, then I feel pretty comfortable saying like, okay, I'm just making this up and it's not really big. So in general, no, I think I use more of like a subjective mind. But sometimes when I'm unsure, yes, I do rely back on that. I just wouldn't use it as a hard and fast rule. Great question. All right, I'm going the wrong way. Okay, ready for Theo?
Yes, thank you so much. And thank you all for the questions.
Absolutely. All right, so Theo is a 7-month-old staffy who's here for vomiting and lethargy. These are Theo's radiographs.
Someone has said pit bull, it's a foreign body, LOL. Foreign body. Obstructive pattern right there. GDV question mark?
I love that thought about the GDV. While everyone's looking, I just want to go over why this isn't a GDV. So GDVs, and just want to remind you, you can only identify on the right lateral projection. Every once in a while, you'll see a left lateral projection that looks like a GDV. I don't know why that happens. Ignore it. The only projection you can use for a GDV is the right lateral. And I understand why you would say that, right? It has like that double bubble Popeye arm. The thing is, it's facing the wrong way. So for it to be a GDV, get out my trusty pen over here, the pylorus has to come up and move craniodorsally facing this way, whereas the pylorus in this is coming up here and facing caudally here. So I totally understand why, like the similarities between those two, but because it's not craniodorsally displaced, it's not a GDV. I love that thought process, and I'm glad we were able to discuss that. And then my other question I want to ask you guys: do you think there's a fusion in this dog?
Few other answers while people are saying that, I will share. Some others said interstitial FB, different gas size. And thank you, Grace. They said that your answer on GDV was helpful.
Love it.
He's thin.
Great. I love all of these.
No
All
effusion.
right. One no fusion. Anyone else?
Possible peritoneal effusion looks like decrease.
Pleurisal
Ceres.
detail.
Yes,
Okay.
it's getting interesting.
All right. Well,
Low
let's
grade
see what the.
effusion, no effusion. Scant cranial ventral. Is there free
Okay.
gas?
Good question. Is there free gas?
Another free gas question mark?
So these are places where, again, AI shines. AI is great at identifying peritoneal effusion, pneumothorax, pneumoperitoneum. And so if this is your case and you're like, oh my God, I don't know, is there an obstruction? Is there a GDV? Is there effusion? Is there gas? Like you have this vomiting dog. I'm not even sure where to start, right? These owners may, maybe they're on the fence. Are they going to admit? Are you going to refer? So in 5 minutes, you'll have this AI generated report. All right. So we are finding on here small intestinal mechanical obstruction and then some other colitis, gastric material, gastroenteritis. So let's go through these. But actually, before we do, I just want to draw your attention to the peritoneal space here, which is showing normal. Okay. And so again, we're not going to just blindly trust the AI. But as you use AI more and as you become more comfortable with Radimal and with AI interpretations, you kind of learn where the AI is just really great and trustworthy. And some of that has to do with the things we talked about, like are the radiographs positioned? Is there one view? Are there 5 views? Like how likely is it for the AI to identify the abnormalities? And so some of this just comes with using an AI product. All right, small intestinal mechanical obstruction. It's certainly highlighting a reasonable area, right? Like some of these look pretty big. It's detected in 2 of the images. I'm feeling pretty good about this. And it sounds like a lot of you were concerned that maybe he had a small intestinal mechanical obstruction. I think in the interest of time, I didn't put through the rest of them. Colitis. There is actually some gastric material. If we look right there, there is some gastric foreign material. So pretty cool that the AI was helpful in picking that up as well. And again, kind of like the cardiogenic pulmonary edema, I had worried there's an obstruction. The AI is worried there's an obstruction. let's stat this consult out to the radiologist so that I can feel more comfortable making that decision about, am I going to cut this dog? Am I going to refer this dog? Are we going to keep this dog overnight on fluids? Am I going to send him home on sub-Q fluids? Depending on what kind of clinical setting you're in, may depend on what your options are. But having that radiologist consultation is going to be incredibly helpful. But hopefully the AI consultation will help you at least get the ball rolling and talk to the owners about what you're concerned about. This is why you want to send it out to the radiologist, and this is what the potential implications of that report will be. And so again, for colitis, it's looking at the right part. Oh, there's the gastric material. And so like, here's a weird one, gastroenteritis. It's not really looking at the right area. It detected it in one image. So I'm gonna, if I'm evaluating this, I'm like, I'm not really sure exactly that the AI picked this one up as well as I would have liked. All right, so let's talk about this. Does this dog have mechanical obstruction? Does anyone have a number in their mind for how big small intestines can be in a dog? And we're gonna compare it to L5, if that rings a bell for anyone.
1.6, less than 1.6,
I love it.
1.6, 2.5,
You guys, you guys are on it. You are,
1.5.
yeah, great. So we're going to measure intestinal segments. I want to remind you, you cannot just measure the gas-filled lumen. You have to measure the wall. And so I hope you can see, I couldn't make it like really quite as precise as I wanted, but I hope you can see, especially on the right lateral projection, the left side of your screen, that I've included the wall in that measurement. That's really important, especially when there's intestinal segments that are fluid filled. And so we're going to measure those. We're going to measure the height of L5, not the length, the height. 1.6 is kind of the magic number in my mind. So there's a paper out there, it gives like lots of different ratios. If it's like 1.4 to 1.6, it's this sensitive, specific, etc. 1.6 is kind of the number that I use in my mind to be like, okay, if it is 1.6 or greater than the height of L5, then I am very concerned there's a foreign body. If it's greater than 2, it's like, I think it was close to or almost 100% sensitive and specific, as long as there's 2 populations of bowel, right? Not if there's not if there's a functional ileus. And so that's kind of the questions that are kind of milling about in my mind. So in order to identify mechanical obstruction, I need 2 populations of bowel, one that is severely distended, greater than 1.6 times the height of L5, and 1 population of bowel that's normal. And so when you're looking for normal bowel, all these segments here, these are totally normal diameter bowel. So right off the bat, I know I have 2 populations of bowel. I'm highly concerned there's an obstruction. I'm going to do that measurement. I do measurements often in the clinic. And in this case, it measured, I believe, 1.9 or 1.8. And so that's going to, again, increase my index of suspicion that there is a mechanical obstruction. Does anyone see the obstruction? Because I think that we can make it out. It's not very radio opaque, but does anyone want to take a guess at where it is? When I say it's not radio opaque, I mean it's not mineral opaque.
I
All
don't
right,
have any
well,
guesses. So, oh, caudal abdomen.
yes, it is caudal abdomen. Which projection, right or left, do you think you can see it the best?
Someone's also asked, can you show comparison with I5? Someone wrote left, someone wrote ventral to L4 to L5, right, right, left, right.
Can you just repeat that question? Can I show a comparison what?
With L5.
Yeah, so here's L5 measured here. And so when you are in your like normal imaging software, whether at Radimal or whatever you happen to use, when you use the ruler, it'll give you a measurement. So let's say that L5 measurement is 1 centimeter, whatever it is, but let's just pretend for ease it's 1 centimeter. And the other intestinal segments that I've measured here or this one, like I'm just kind of picking out ones. A lot of times I'll measure 5, 6, 7 of them just to kind of make myself increase my confidence. And if this one is measuring 1.6, 1.7, 1.8 to the 1 centimeter of this height of L5, then that is highly sensitive and specific for mechanical obstruction. I do want to caution you, and I kind of mentioned this, you still have to have two populations of bowel, because if all of your intestines are distended, then you're probably more likely dealing with a functional ileus, not, like uh, a non-surgical enteritis versus a mechanical obstruction that requires surgery. So you do need two populations of bowel. Don't forget that part. And so this case did go for specialist consultation. And one of the cool things about Radimal reports is the radiologist can kind of draw your attention to the area that they're looking so that you're not just like, okay, what did they say? Ventral to L5 on the right lateral, and you're like, it takes you 5 minutes to even find what the radiologist is describing. The radiologist can point it out. And that's really helpful too if we're talking about nodules, small fractures. And so in this case, I believe that's the foreign body. This dog has a mechanical obstruction and should be sent to surgery. And because the clinic statted this case, they got it back, within 20, 30 minutes, most likely, and were able to either get the dog into surgery or refer it out for surgery. I think mechanical obstructions are probably one of the most common things that we see statted because, they have such a need to go to surgery. Any
Andrew, while
question?
oh, sorry. We have one
No, go
question
ahead.
that's sort of on that note, and I
Mhm.
welcome any other questions in the chat while we ask this one. What is the most common diagnosis you get from radiographs in general? I thought that was a
Hmm.
little similar from what you had just mentioned about obstructions. Thank you.
If we're talking about the most common thing that we just see on a daily basis, and mind you, I'm in a hospital that is specialty NGP. At Radimal, we have a mix of GP and specialty and ER. The most common things that we see are incidental findings, spondylosis, stifle, OA, things like that. If we're talking about like really specific conditions, I think in dogs, mechanical obstructions or gastric material. And if we're talking about cats, I'm going to say bronchial patterns that people are unsure if it's bronchial or if it's heart failure. I think those are probably the most common. Second to musculoskeletal, because I think that's something that's just tricky for everyone. Like, is the digit fractured? Is this line in a young puppy something to be concerned about? So we definitely do a lot of musculoskeletal imaging as well.
Thank you. A few more questions. Um, was there free gas?
Oh, thank you so much. Totally forgot. I do not believe that there's peritoneal effusion, and I do not believe that there's free gas. So when I look for peritoneal effusion, I'm kind of looking in these little pockets right here between the stomach and the spleen. On this view, I'm looking here. I'm also going to look at some of these little areas like between intestinal segments. And the fact that I can see where one starts and stops makes me feel like there's probably not a fusion. Um, and also, again, the AI is quite good at that. And so I'm also going to allow that to sway me a little bit. The good thing is, even if I were, let's say I really kind of thought that there was a little bit of effusion, that's okay. It wouldn't be uncommon to have a small amount of effusion in a small intestinal mechanical obstruction. Um, it certainly could indicate sepsis, but generally those are going to have more effusion, and you would probably be able to pick that up radiographically. So if you're kind of like going back and forth, is there not? In reality, it probably doesn't matter that much. I personally think that this patient has appropriate serosal detail, and I'm mostly basing that on cranioventral in some of these little pockets. I think there's good detail. Um, I did, I do wonder, and feel free to put it in the chat. The spot that was equivocal to me for free gas is here and here, like right along this kidney margin. I thought these were kind of weird gas opacities. Um, the place that I find most helpful to look for free gas is right along the diaphragm on the craniocaudal projection and along the diaphragm on the lateral projections. I don't see any free gas there. I don't see any bubbles of free gas. And usually, like, if you're going to see big gas pockets like this, you would probably see other little bubbles of free gas. And so, like, if you're looking in this area and seeing gas, I think all of these are in intestinal segments. I think these are all in the colon or in an intestinal segment, most likely. And I also think some of this kind of heterogeneity and texture that we're seeing here could be the foreign body itself. So again, I think these are all things that are running through my mind, are super important for you to ask yourself. Are there two populations of bowel? Is there a mechanical obstruction? Do I see free fluid? Do I see free gas? Right? Like these are all things that are going to determine what we're going to recommend to these owners and how we're going to treat these patients. And again, the AI is there to support you and help increase your level of confidence. Thanks for reminding me to mention the gas and effusion. I'm glad we got to talk about that.
Thank you. I have a couple more questions. A few of them are all similar, so I'm going to ask them as a group and then come back to
Mhm.
one last one. So where do you think the obstruction is? Which view best describes the obstruction? And please outline the obstruction.
So, okay. So sometimes you cannot see the foreign body, and that is okay. Things like rubber, plastic, glasses, lenses, sometimes even squeakers just are not radio opaque. And so if you don't see the obstruction, if you don't see what is causing the obstruction, the actual foreign body, I don't care. That doesn't mean the dog isn't obstructed, and it doesn't mean you're missing something. Sometimes you just can't see it. In this case, I think this is the obstruction. Let me get my drawing thing out here again. I think this is the foreign body. I'm not quite sure where it is on this one, somewhere in this general area, and I don't know where it is here. And so when I'm asking myself, are there two populations of bowel? You have to make sure you're looking at small intestine. And so what I like to do, and I'm using all the images, I'm like constantly going back and forth, and I definitely recommend three views when you're worried about an obstructed animal. Sometimes things really just show up a lot better on the left lateral, especially if it's in the pylorus, especially if it's in the descending duodenum. But so what I do every time I look at a rat, I say, okay, where's colon? Here's colon here. Here's colon here. I don't know where it's going from here. And cecum is somewhere in here. And so, like, I don't know, maybe that is cecum, not small intestines. Then I'm like, okay, let me try on the other one. I can't really even see colon well here. Maybe it, oops, excuse me, maybe it's this. I don't know where colon is here. I cannot determine that. What I do know is that colon does not come down here. Colon doesn't come down here, right? The colon will come across, and then you'll kind of get transverse to ascending and the cecum. And so on this VD, I'm not sure where colon is. I think this may be the diameter of the colon. So I'm going to say colon's going to come up here. I don't know, but I'm guessing transverse colon, ascending colon, cecum somewhere in here. I don't know. But what I do know is that this isn't colon, this isn't colon, these are not all cecum. And so it's kind of like process of elimination in figuring out what's colon, what's left, and can I make a case where some of those have to be small intestine? Hopefully that answered the question. But again, to just reemphasize, just because you don't see the foreign body does not mean that the dog is not obstructed.
One last question and then we'll move on. Uh, is the foreign, if the, excuse me, if the foreign body is that far caudal, why is the bowel diameter normal there?
So you have to remember just because the foreign body is caudal in the abdomen does not mean it is distal in the intestines. And that can be very tricky. Sometimes you'll see something that's like right here, and you're like, oh, maybe that's near the ileocolic junction, but you really have no way of knowing that. Sorry, I don't know if you can see that. I was saying it might be like you might see a foreign body here, but you don't know that it's at the ICJ unless you can trace colon. And so I don't know why exactly. Like, if we look here, why isn't this segment of bowel and this segment of bowel more distended? I don't know the answer to that, but I kind of just, it doesn't matter. The only things that matter are there two population of small intestine? If so, there's a high level of concern for mechanical obstruction. Like that really, the like that's kind of where I try to come back to, because I think it's easy when you're looking at these to be like, oh my God, there's so many things distended. I don't know, it's colon, I don't know, it's small intestine. Like, okay, what is small intestine? Is one severely distended? What are the measurements? If you're worried, send it out for the radiology consultation.
One more question. So,
Sure.
keeping with your thought process on how you identified the FB gas?
Um, can someone clarify what you mean?
Nancy, could I ask you to provide some further details in your question? What
All
drew
Nancy's.
you down to the FB? Thank you, Nancy.
Say that one more time, Madison. What?
What drilled you down to the
Mm.
FB?
Honestly, so because there's nothing mineral opaque, I'm like, okay, it's not going to be super obvious. So then I just start looking for things that have some texture. And this is kind of just a textured area. If I make this bigger, can you guys see this bigger now?
Yes, thank you.
Love it. Sorry, it took me 3/4 of the presentation to realize that, even though you told us that earlier, Madison. So you can see this area has some texture in it. That's probably the foreign body. You can see it has like little mineral um, horizontal lines there too. I'm just guessing that's the foreign body. I could be totally wrong, and I have no way of knowing whether that's correct or not. Um, I don't spend a whole lot of time worrying about where the foreign body is because it's somewhat irrelevant. As long as I have small intestine that are distended and small intestine that are normal, then somewhere in the small intestine, there is most likely a mechanical obstruction, and that needs to go to surgery. I know it's
Nancy,
always like really rewarding to like find that foreign body, but it just doesn't always work that way.
Nancy says thank you. And someone else added gas in intestines pushes foreign body more caudal, I think.
It's possible. So, like, if maybe what people are asking is why are the intestines so bunched back here? I think it's because a lot of these intestines are big and fluid dilated. And so I think it is just sort of creating a mass effect and pushing other things caudally. But that's not always the case. It just sometimes looks that way. Foreign bodies are still, 12 years into being a radiologist, some of the most challenging things. And just when you feel very confident, you'll send something to surgery and there's no foreign body. And so they're very challenging. Radiographs only show so much. If you have the opportunity to offer ultrasound, I think that's always helpful. Certainly in clinic, even when I feel pretty confident that there's a foreign body, I still like to ultrasound them first just to make sure, give that additional level of certainty. And I know on the referral side, when you guys send out cases to a specialist and are looking to find out if there's an obstruction, and maybe the radiologist comes back saying like, I'm just not sure, maybe there is, or I think there is, I recommend surgery, and then maybe the results aren't what was dictated in the report. I wish there was a better way to find a foreign body. They're just very challenging. They can have a very varied look and appearance. And it is certainly an imperfect skill and art that all radiologists are working on honing. I do just want to keep going, Madison. I think we
Yeah,
have
we're in
one
the
more case to
interest of
do.
time. Thank you.
Okay. Pookie, old Bijan, possible stroke, anemia, increased ALT. Another case with a lot going on. I'll give you guys a minute to look. And I think we're going to move through the AI findings a little more quickly so we can talk about the case ourselves. And anyone who's able to
Trisha
stay 5 more
says,
minutes.
holy moly. That was such a great
Yes,
answer. Thank you.
agreed.
That mass affect much? Damn, big mass,
Exactly.
big mass.
Looks like a potato.
Someone wrote, whoa, Batman spleen? Yikes on bikes.
Yes. Do you guys think there's a
Splenomegaly.
fusion?
Do you think there's a fusion in case I was talking over Dr. Weissman? Nope. Thank you, Dr. Wright. No, no. Mass with effusion, not on lateral question mark? Large abdominal mass, no effusion. Many no's, nada.
Okay, let's look. All right, again, we've got lots of things. Right at the top here, the AI is identifying peritoneal effusion. We're going to talk about that as we go. Um, all right, we've got hepatomegaly, abdominal mass, and then a couple other, shoulder degeneration, spondylosis. Let's get moving. So, peritoneal effusion. The AI is saying this is very likely. It's identifying it on 3 images. I have to tell you, even as a radiologist, when I see the AI this certain, it makes me wonder, like, is the AI picking up on something that I'm just unable to see? And so I'm looking at the AI in this spot. That's where it's looking. So I'm going to go back. This is truly what I do in real life. I go back and look at this spot. And I'm like, you know what? It is slightly wispy, amorphous. Maybe that is scant effusion. I'm going to kind of take the same approach as I took with the foreign bodies. If we're dealing with that tiny volume of effusion, it probably just does not matter. But I think it's interesting that the AI is looking here, and I can imagine whoever talked about bringing their imaginoscope, I can see what the AI is seeing here, and maybe there is scant effusion. All right, we've got a huge abdominal mass, right? The AI is not going to tell us where the mass is coming from. That being said, sometimes the AI can tell us, but in this case, it's not. It's just saying there is an abdominal mass. It's saying that there's hepatomegaly. We've got a little gastric distension, shoulder OA. Again, it's going to pick up all these little findings that we tend to gloss over because we're looking at the potato-sized mass and we're not looking at the shoulder degeneration or the nodule on the edge of the image. Not that there is one in this case, but that's where the AI is going to be great. So when we're talking about masses, we need to look at the gastric axis. So the gastric axis is here. It's got some gas in it. Anything cranial to that is going to be liver. So this whole thing is liver, comes down here. It's got like a kind of bulbous margin here. And so a lot of you said a splenic mass. I believe that this is most likely splenic in origin. I will tell you once in a while, you can get a huge pedunculated liver mass. But I think most likely this is spleen. I think that's why it's mid-abdomen here. That's kind of where spleen lives. We're going to take that peritoneal effusion and just kind of put it in the maybe category. And I think that's it from the AI perspective. And so again, like I know everyone can look at this and say like, oh, there's a mass, but I think it's really helpful to have the AI to say like, okay, here's the mass. Maybe there's some effusion because that might prompt us to reach out to a radiologist. That might prompt us to AFAST the dog to look for effusion or do a 4-quadrant tap. That might prompt us to talk to the owner and say like, there might be a little effusion. The AI is picking up on it. Do you want a referral to an ER to assess for effusion? Or, when you go home, you should really make sure that your pet isn't, having shortness of breath or weakness, something that might indicate that there is active bleeding. And so again, these are just lots of little tidbits to help really create a better picture about what is going on in your patients. And so on this specialist report, same thing. We've got an abdominal mass, effusion. This radiologist did not mild peritoneal effusion and consider hemorrhage given the anemia. And so, I think it really, again, it's radiology is not a hard and fast science. Unfortunately, I think we all wish it was. It's an art. And I can tell you that even as a radiologist, I enjoy using the AI to kind of point out areas that I may have glossed over. And yeah, any questions about this case? If we're talking about differentials for this splenic mass, I know that we tend to say like, oh, it's a big splenic mass, it's cancer. I just want to remind you that just because there's a splenic mass, even if there is scant effusion, it could be nodular hyperplasia, it could be extramedullary hematopoiesis, it could be a hematoma. It could be lots of weird things too, but those are like the three most common. Certainly, it could be hemangiosarcoma or some round cell tumor. But I just want to remind you that just because you see a huge mass does not mean that it's neoplastic. And in fact, there's some evidence, there's a paper out there that shows that the bigger the mass is, the less likely it is to be neoplastic. If there is a large amount of effusion, we do start putting neoplasia higher up on that list. But ultimately, those patients need to go to surgery and have splenic biopsies performed.
We're getting some very funny comments. I'm glad I was muted because I was laughing out loud. Someone said, "What on earth is the shoulder note all about?" And I'm not, I might have missed that from the.
You know what? I think it's because I wanted to make the image bigger so that you guys could see it. So I must have taken the shoulder out of the image. So that's why, yeah, you can't see shoulder OA, but this is a picture of this patient's shoulder, and you can see that there's a little bit of osteoarthrosis right here. And so that's why it's coming up with shoulder degeneration. But thank you for whoever pointed that out. You're totally right. I didn't even realize that I took that out of the
Thank
image.
you. Very helpful. Thank you. I have two more questions. How good is the AI for screening for Mets with old dogs? Sometimes the age-related pulmonary changes and liver calcifications throw me off.
Unfortunately, the AI is not great at identifying small nets. And the AI also gets confused by the same thing, whether it's mineral or soft tissue. It's something we're currently really workshopping at Radimal, and I'm hopeful that in the next 3 to 6 months that I'll have a different answer for you. There are times similar to the fusion where the AI will identify a nodule and I will go look at it and be uncertain myself. And so I do find it helpful in pointing out some nodules, but I do not feel comfortable heavily relying on the AI to determine osteomas versus nodules. I think that's an area where having a board certified radiologist would be more appropriate.
Thank you. The next question. My dog had a leiomyoma on the spleen,
Mhm.
and it was big and it was benign. So, like you said, you don't know until biopsy.
Yeah, absolutely. There's a really interesting paper. I can't think of who wrote it, but yeah, it showed the bigger the splenic mass is, the more likely it is to be benign. And in my memory, the reason is because it's more likely to be a slower growing mass, and so it's less likely to be necrotic and bleed. And so something like a leiomyoma, would be a more slow growing mass. Certainly not a reason to euthanize. Thank goodness that you took your dog to surgery. That would have, been terrible. So yes, I absolutely think that's something that's really important, and we, talk about it at work all the time. Just because there's a mass, whether spleen or liver, anywhere, you don't know what it is until you've biopsied it, until you've FNA'd it. You can recommend they go to see a radiologist to have an ultrasound and fine needle aspirate, or recommend surgical biopsies. But you don't know what it is until biopsy.
Andrew, can you keep sharing? We have a couple other questions, and I know there are a few other slides. My colleague has had four benign splenectomies in a row as of now, smiley face. And I'm
Mm,
so sorry again. I am the only non-medical person on this
you're doing
webinar,
a great
so
job.
so sorry. Um, and then also wanted to go back. There was a question from earlier from Courtney that my apologies, missed. So this was on the second case. Um, is the tibial slash tarsal lysis consistent with fungal disease, possibly valley fever?
Great question. So being from New Jersey, that is something that I have the luxury of not thinking a whole lot about. Absolutely, this could be valley fever. This could be it of the infectious diseases. I think valley fever is the most likely. In this patient, was she old? 8 years old, so like kind of mid-age. And so absolutely, I think that's a very reasonable differential, and kind of similar to the spleen. You don't know what things are until you biopsy them. And so yes, another great differential. Thank you so much for pointing it out, especially with, a lot of you seem like you're coming from all over the country, and certainly I'm guessing a lot of you see things like valley fever commonly.
Wonderful.
Um, Madison, I think actually I don't have any other slides. And so if people have questions, I'm happy to keep answering them.
One other question, if AI says normal, how is that reliable?
I think it depends on what it says is normal. And so I think when we're going through the AI findings, um, I like to I'm trying to think of how to explain this. So, one, I'm going to take into consideration how good are my radiographs? Is it one whole body radiograph? Is it three views of just the thorax? Is it positioned appropriately? Is it taken on inspiration, right? Like all those things truly matter. because you're talking about a computer analyzing images. Um, at the end of the day, whether the AI identifies something or doesn't, we as doctors are going to have to make decisions. And I wish I had a better answer, but it depends on what the disease process is. It depends on what the radiographs look like. And I think it's just really important to take the whole case into consideration, take the patient that's in front of you. And if you have questions, submit for radiology consultation. Like I cannot overemphasize that enough. The AI is not meant to replace a radiologist. The radiologist will help synthesize any AI information and will help answer those questions. Is there a fusion? Is there free gas? Because there's just, currently the state of not just veterinary medicine, but human medicine, the AI is not replacing the radiologist. I know that's probably an unsatisfactory answer, but that is the truth of where things stand right now. And again, that's not just here in this talk, but in veterinary AI and human AI.
Just like Andrew said before, we believe that only doctors make decisions.
Yeah.
Would you mind resharing again? There is one more slide with a QR code that I would like to share
Yes.
with everyone, please.
Hopefully, I'm not giving everyone a seizure by there we go.
Thank you all.
It's been really wonderful going over these
Thank
cases. We would
you.
love to do this again. We hope you guys will join us again for another case rounds. And if you guys have particular cases, either that like topics you'd like to see or particular cases you'd like to see, feel free to drop us a note. I'd be happy to kind of curate some cases around what people are interested in. And if you haven't tried Radimal, I would love to, we offer free trials. And so you can go right onto our website, radimal.ai. You can make a free account and your RADs can come to us same day. And you can try the AI for yourself, get to know our radiologists a little bit. We have a wonderful group of radiologists. And I think my favorite feature about AI is this little pink button on our website where you can chat directly with a human being. So when you have a question about like, I wasn't sure if the nodules were pulmonary osteomas or METs. Please clarify. You have a real person on the other end of that that can answer those questions for you. And I think that's one of the wonderful things that we offer, and for trying to bridge that gap between you waiting in the clinic and needing these answers now, and us being on the other side of the screen.
Thank you. Just to reiterate, thank you all so much. This is going to be the first of many. We really hope you will continue. We did get a question, or could you do a talk correlating RAD review and POCUS fast scan? So we will take that into
Definitely.
consideration. Christina, we will. I can send you a follow-up with answers on some of that pricing, but basically you can try out the AI for free, and we'll also give you your first 3 specialist reports for free. So you can experience everything in Radimal's workflow with no cost and no risks at all. And we will be sending you all of your CE certificates in the next few days. So thank you so much, and no worries about that. We'll make sure you get those certificates. And so appreciative for everyone's time, your questions, your enthusiasm. It was very exciting for me. I learned so much. And like I said, I was probably the least knowledgeable, but so grateful, and looking forward to doing this again with all of you really soon. And if anyone has any other questions, I will also just put my email into the chat. It is Madison, Madison, at radimal.ai. And I'm available to support anyone with any additional questions, as well as be able to get them to Dr. Weissman. Thank you all. I hope you have the rest of a wonderful evening. I hope you enjoyed your popcorn, other snacks, and yeah, can't wait to chat with you all again soon. Thank you.
Thank you all.